So you can do this FE1 by FEC ratio, and then based on this, you can say whether it is if the vital capacity is greater than equal to lower normal limit, or if it is not less than equal to greater lower than volume limit. If it is normal, you can go for a DLCO, that is another test, that is diffuse lung capacity for carbon monoxide. If it is greater, yes, the patient is normal. But again, if it is no, it can be a pulmonary vascular disorders. If the vital capacity is not less than equal to the lower limit value, it can be a restrictive disease. You perform a DLCO, it can be either neurovascular or chest wall disorders. If it is, if no, it can be a ILD. And the same applies for this. If it is greater than equal to normal value, it can be either obstructive defect versus a mixed defect. You can go for a DLCO if it is lower than, or if it is greater than equal to the lower limit of the value. That means it is a patient of asthma. If no, that means it is a patient of COPD or emphysema. So acute state where inflammation, airway edema, excessive mucus accumulation, and severe bronchospasm result in narrowing and poorly responsive to usual bronchodilator therapy is COPD. So there is a lot of mucus production, there is a airway edema and poor responsive to the bronchodilator therapy. Why this airway edema? Why mucus accumulation is being there? The alveolar walls are distracted. There is a air trapping mechanism. The patient who is breathing the oxygen is not able to pass the alveoli to go to the blood vessels, and the toxic carbon dioxide air which is there inside our body is not being able to back diffuse to the alveoli to be exhaled out into the atmosphere. So the patient can present with acute distress, severe shortness of breath, chest tightness, and the patient will able to say very few words. And if you make auscultatory examination of the patients, he will have a dry hacking cough, increased respiratory rate, tachypnea, even increased heart rate, tachycardia, maybe a pale or cyanotic skin and a hyperinflated chest. One of the clinical important signs of COPD. Why? Because there is an air trapping mechanism. Because of that air trapping mechanism, the air is not able to wash out the CO2, and that CO2 start accumulating in the alveoli, that there is distension of the alveoli. Because of that, there is distension of the lungs. And if you see a classical picture of the COPD, the lungs appear more of increased in size or hyperinflated because of that air trapping phenomena.